Hello everyone, my name is Dr. Arvind Bhatkar. So today we'll be talking about a very dear topic of mine, spine pain management, when and what to do in it. Right. So the topics we will be covering is drugs used, the nerve root blocks, the epidural injections, the cervical and the caudal, the facet joint blocks, the SI blocks, the sacroiliac blocks, and vertebroplasty. Now here we are going to talk about the drug used. So the first drug used is going to be lignocaine, in which you can see that it's an intermediate acting amide based long lasting local anesthetic with the maximum dose of about 7 milligram per kg, and with adrenaline you can give about 4.5 milligram per kg. Okay, now in terms of bupivacaine, it's a long-acting local anesthetic and amide based. So in this, you can give a max dose of about 225 milligram with adrenaline, and without adrenaline, you can give 175 milligram. Lastly is triamcinolone. It's a particulate glucocorticoid which can be given as an intra-articular injection. And lastly comes dexamethasone, which is a non-particulate steroid, which is generally given in cervical epidural steroid injections. Now, in terms of the other drug used for the radio-opaque dye, what we use to delineate the nerves is the iodine gives its radio opacity, and it is ionic and non-ionic. There are two types, ionic and non-ionic. Generally, we try to use the non-ionic ones, which have less adverse drug reactions. Okay, and the brand names are like iohexol and iopamidol. Allergy to the shellfish or seafood has no connection with the contrast dye, as has been amply described by these papers. So why do I use the dye? It's to delineate and to prevent any intravascular flow of my drug, okay, which can cause a lot of complications later on. If there is a true allergy to iodine, you can use gadolinium for contrast. Okay. Now the thing is 5.85% of epidural injections can be intravascular. Hence, we need a dye to find out that it's not going intravascular. So we'll be talking about nerve root blocks, the lumbar nerve root blocks. So what is the treatment and what is the indications for that? So generally, these lumbar nerve root blocks are given as a dual treatment, as an therapeutic and diagnostic uh, factor into that. So who to give? So the patients who have not been relieved by pain medications and rest, and have no motor deficit, and have got a prolapse into vertebral disc, generally a single one, I would like to give a nerve root block. So what to see before you give a nerve root block is, first you need to see the patient. In terms of examination, you need to find out what is the dermatome in which the patient might have the pain. So here you have the dermatomes, which you typically ask, and the patient, if prod properly and asked properly, will give you a good history. For example, if the patient has got an L5 nerve root compression, they will tell you on the lateral side of the leg they have got pain. And if the patient complains of pain in the calf region, it might be the S1 nerve root which has been compressed. Similarly, you need to do X-ray to find out if there is any unstable listhesis, which generally I don't tend to give injections in, because these are mechanical problems which need a mechanical fixation to solve their problems. Lastly, you need an MRI to see the target disc and the side of the disc compression, whether it is on the left or the right side. Okay. Steps for the nerve root block. So what all injections and the other things what you require for a nerve root block? Requirement is, first I need an 22 number black spinal needle. Second, I need syringes, the lever lock syringes. So I need a 5 ml syringe in which I take, which is a lever lock syringe, which I take 40 mg of quinolone, which is triamcinolone, plus 1 to 1.5 ml of bupivacaine, And in another 5 ml syringe, I take a dye of 3 to 4 ml iohexol. And lastly, in a 10 ml syringe, I take 2% of lignocaine of 5 ml and distilled water of 5 ml. Lastly, we take a thick pink needle for aspiration of the drug and later for marking on the X-ray. Now, what are the contraindications for these injections? First is uncontrolled diabetes. So my threshold has been generally about, if the random blood sugar is more than 140 and the patient has got diabetes, I generally tend to not give the injection in these patients. Then if the patient has got spinal infections, if the patient previously had a surgery in which I can see an florid calcified fusion done, so a caudal epidural steroid injection can be a salvage in these patients. And lastly, if the patient is on blood thinners, I wouldn't give them injection until the blood thinners have been stopped for adequate amount of time. Now, in terms of the technique for the nerve root block, first what you do is you make the patient lie down on a table which has adequate amount of clearance on the lower side, and there is no rod coming inside, and the patient lies down stable prone, and then we take an X-ray. In an X-ray, what we do is we parallel the end plates. So once the end plates are parallel, what we do next is we turn the C-arm to the side in which we are going to give the injection. Okay, and then you'll get this kind of an picture, which is similar to a Scotty dog image, in which you can see that this is similar to the face and this horn is similar to the horn of the Scotty dog, and this is the neck of the Scotty dog, and here is a neck, and the target where you need to keep your needle is going to be this neck of the Scotty dog. Similarly, here you can say this is the neck of the Scotty dog where the target is there. Okay, so again, now here you can see that the needle has been already put in. So this is the needle on AP, and then you take an true lateral and see that the needle has gone in the intervertebral foramen. Okay, you have to be very careful while pushing the needle through because it can injure the nerve over here. You have to be very careful. If the patient mentions of any radiating pain, you might have to retrieve the needle a bit. Okay, lastly, what you do is you give the dye to see the flow of the dye, and you will also see a bit of a flow in the epidural region in the midline, and then you give the drug. Now let's come to epidural injections, the caudal and the cervical. So who to give? These are the patients who have not got relieved by any pain medications and rest and have not got any motor deficit. So caudal epidural injections I generally give in lumbar claudication, in which bilateral neurogenic pain is there in old patients. Cervical epidural I generally give in patients who have got cervical radiculopathy, whether it is unilateral, bilateral. I generally don't tend to give cervical nerve blocks because those have high chances of complications. Now, what to see in these patients? Again, similarly, for a patient, you see the dermatome and the motor function. In X-rays, I tend to see if these patients don't have any unstable spondylolisthesis. And lastly, in MRI, if for cervical epidural, I see that these patients have got an multi-level lumbar canal stenosis, and I need to rule out if there is any vascular claudication present. Now the technique for caudal epidural, again here you can see the cocktail. What I generally give is 4 ml of 1% lignocaine, 4 ml of 0.5% bupivacaine, distilled water of 10 ml, and 2 vials of quinolone, that is 80 milligram. It all becomes a 20 milligram cocktail which I give in this epidural space. So there is a potential space in the lumbar region where we give this injection. Okay, and first we give an local anesthetic at this region, and then we pass the needle inside, and then here you can see when the dye is given, and you can see a free flow of the dye, contrast dye, and last on AP we see this way, and then we give our drug, which is given slowly so that the patient doesn't feel any pain in the back. Okay, now let's come to the cervical epidural. So cervical epidural, how we do it is first we make the patient lie down prone, okay, and we try to find out the C7T1 region, okay, and the needle lies on the same side as the as a side in which the patient has got radicular symptoms, okay, and you aim generally on the superior edge of the T1 lamina. Okay, so this is the T1 lamina. Okay, here is your rib coming out, and you aim at the superior edge of the T1 lamina. Okay, and once you have reached the superior edge of the T1 lamina, you turn your needle from down to up. Okay, so down to up, and once you do that on a contralateral oblique angle, you can see that your needle slides in to the epidural space. Once you are in the epidural space, you give the dye this way. Once you have given this dye, the dye completely goes into the epidural space, and then you slowly and steadily pass your drug, which is about 16 ml of dexamethasone, that is 2 vials, and look for any intraarterial extension. If there is any, you retrieve the needle and try again once more, and if still there is no success, you just abandon the procedure. Okay, now comes to the facet joint blocks. So facet joint blocks are generally given in patients who are not relieved by pain, medications and rest, and have no radiculopathy. So facet joint block will cause you back pain, just pure back pain. Okay, and there will be no radiculopathy. Okay, so what to see? The facet joint pain on movement, and it radiates to your buttocks sometimes, but it doesn't go back in your legs. On X-ray, you might find a bit of facetal arthropathy, but it is confirmed on an MRI as there is a lot of fluid in these facet joints, and also the facets are enlarged. Okay, over here what you can see as hypertrophy. Okay, so what do you do? Again, the same technique in which you make the patient prone. You again parallel your uh, lumbar vertebra, and then you you actually turn your C-arm again to the same side where you are going to give your injection, but the only target level, before it was the neck of the Scotty dog, now this time it is the angle between the ear of the Scotty dog and the head. So here you can see this is the head of the Scotty dog, and this is the ear of the Scotty dog, and this is where the facet joint is. Again, this is where the facet joint is. Okay, so here you can see the level. Okay, here you give about 2 ml of drug for facet joint. Now coming to the SI joint blocks. So who to be given? Again, to the patients who are not relieved with pain medication and rest, who have not got any radiculopathy. What to see? The SI joint tenderness. You will specifically find out that the SI joint is tender, and your aggravating tests like figure of 4 and pump handle test are positive in this. On X-ray, you might find the SI joint has got arthritis, but that is confirmed on an MRI. Here you can find good amount of sacroiliitis. Okay, but what you need to rule out in these is there is no infection before you give the injection. Again, the SI joint, what you do is you focus on the SI joint, and you turn the table on the opposite side. So basically, if you are giving injection on the left side, you turn your C-arm to the right side. Okay, so if this is the if you are giving it on the right side, you turn your C-arm to the left side. Okay, so here you can see the SI joint properly seen. This is the previous nerve root block I have given, so here you can see that, but here you can see SI joint properly delineated by the contrast. Okay, and here you can give the injection. Okay, now lastly comes vertebroplasty. So where it is given. So generally vertebroplasty is done in osteoporotic spine fractures or metastatic spine fractures who are not able to mobilize. Okay, generally we try to give an conservative management for these patients, but if the pain is significant enough, so we do vertebroplasty in these patients. So who to give? Not relieved by pain medications and rest, no radiculopathy and no infection. These are two contraindications. So if you have got radiculopathy, that means there is some nerve compression which a vertebroplasty might not treat. Again, if you have got any infection, vertebroplasty itself is a foreign cement which you are putting in. If that gets infected again, you might have to completely remove the cement from there. And what to see? So first of all, you have to see that the neurology is completely normal. Second is you have to see that pain when turning in the bed and while getting in and out of the bed, it is significantly painful. And lastly, it is tender on direct palpation. Now on X-ray, you can see that there is a wedging of at the dorsal-lumbar junction. Here you can see there is wedging and there is a fracture. Okay, also on MRI you can see that there is this fracture. Okay, you have to also see the MRI to find out if this looks like to be an metastatic fracture or it looks like to be an osteoporotic fracture. So the trick in this is, once you find out that the posterior wall of the vertebra has bulged out and it is kind of jutting into the epidural space, that means it's most probably an metastatic osteoporotic fracture, rather than these osteoporotic fractures which don't show any posterior vertebral bulge out. Okay, so what's the technique? So in technique, first you need Jamshidi needles, then you need a sponge holding forceps through which you hold the Jamshidi needle while you are inserting it so that you don't get radiation exposure. Lastly, you can use cement, which is like Mendex or Metronix, which are special vertebroplasty cement and has got a special mixer. Okay, you always use 1 ml syringes, which gives better control and greater push strength when you are pushing the cement inside. Okay, now suppose this is an vertebrae what I see on X-ray. Okay, and these are its two pedicles what I see. Okay, and these are the transverse processes and the spinous process seen. Okay, this is going to be my incision for my vertebroplasty. Okay, and this is going to be my needle which I'm going to rest on the lateral edge of the pedicle. Okay, and once that is seen, then I try slowly hammering it, and my end point is going to be the medial end of this pedicle. Okay, when I am at this medial end of the pedicle, I stop. Okay, so once you have reached on the AP over there, in which you can see that you have reached the medial edge of the pedicle on AP, you see on the lateral, you should be seeing, suppose this is the vertebral body and this is the spinous pro and this is the pedicle, you should have reached just cross the pedicle. Okay, that means the neural structures which are present just posterior to the vertebral body are safe and your Jamshidi needle has reached into the vertebral body. So once you confirm that, you proceed this Jamshidi right inside and you put another Jamshidi similarly on the other side, and once you confirm these both, you put the cement slowly and steadily with about 0.5 ml every time. You have to check an X-ray to see if there is any extravasation of the cement going anywhere else. You need to keep that right in the middle. Okay, these are the X-rays which will show that uh, you have crossed the pedicle over here and you have reached the medial end of the pedicle on AP. Here you can see that I am pushing the cement, looking at the X-ray on CM continuously, and on the final X-ray you can see that the cement has been pushed around. This is about 4 to 5 ml of syringe which I have pushed around, and this gave a very good pain relief to the patient. Lastly, now what are the risks in pain management? Okay, so epidural steroid injections can cause infection, especially in patients who have got high sugar levels. When you're giving these injections, these can cause infections and can cause epidural abscesses, which might need surgical intervention. Epidural injection can cause epidural hematomas, especially patients who are on blood thinners. These might cause hematomas, which can cause compression of the neural structures and which might need surgical intervention. Lastly, vertebroplasty can cause cement leak into the vertebral canal. Very rare, but can happen, and might need an urgent laminectomy and decompression. One of my boss had done this, and he was able to see this and do it because he knows how to do an urgent laminectomy and decompression. Okay, so even with the simplest operation, it cannot be taken for granted that the patient will uh, come through better off or even alive. This was mentioned by Dr. Atul Gawande. So I would urge you guys to go to a specialist who knows how to do surgery uh, before you embark with him for pain management procedures. Now, I would like to tell you one more thing which has actually caused a lot of disrepute to injections. Okay, so this is exercises. So for me, pain management plus exercises is like a Jai Viru Jodi. Okay, so in the famous Sholay movie, the Jai Viru Jodi was actually inseparable. Similarly, pain management without exercise does not work. Okay, so you need to do exercises, okay, compulsorily every day, in the morning preferably, and in the evening if possible, but the morning exercises shouldn't be missed. Okay, so these are the exercises what I generally prescribe. These are pelvic lifting exercises for 50 times, abdominal abs exercises for 50 times. Okay, then bhujangasana, which is a very popular yoga asana, which is also known as an cobra pose. For you take 10 breaths up above and do it for 10 times. And lastly, you do a plank exercise, which you start from 15 seconds, gradually grow up to about 3 minutes in 2 to 3 months. Okay, if the patient is old, they might do on the elbows and the knee, but generally the main young people should aim for knee and toes planks. Okay, lastly, for cervical epidural steroid injections, you need to give these kind of cervical exercises, which have got range of motion exercises, the shoulder exercises, and the isometric strengthening exercises, and lastly stretching exercises. Okay, lastly, thank you for your patient hearing. If you have any questions, please let me know in the comments below, and I'll try to answer those. Thank you.